With a glow of the screen and a heart full of pride, he's talking with experts from the world far and wide, broadcasting his voice through the good and the grand on YouTube, Facebook, LinkedIn, and X across the land. Every Saturday morning, he's the urology man.
Yes, I am the urology man. Good morning, everyone. Welcome to the show. I'm the host, Vic Senese. Glad to have everybody on board. No matter where you're watching us from, we're always glad to have you here. Hey, you probably noticed I got a little unusual surrounding behind me, but I'm coming to you remotely because I'm over taking care of my younger brother who just had to have his prostate surgery because of blockages the prostate. He had a simple robotic prostatectomy, and he'll tell you it was not simple. But we got a great show for you today, so let's get on with that. Today's show, we're joined by Dr. Nancy Brownlee, a distinguished nurse leader with extensive expertise in advanced practice nursing, patient care innovation, and clinical education. Dr. Brownlee has dedicated her career to improving healthcare delivery, empowering nurses, and advancing evidence-based practice. Her passion for mentoring and her commitment to patient-centered care make her an influential voice in the profession. We're thrilled to welcome Dr. Nancy Brownlee to the program. Welcome. And Lori Atkinson joining us also today. Lori, why don't you give a quick introduction, then we'll let Dr. Brownlee introduce herself.
Sure. Hi, my name is Lori Atkinson. I'm a certified urology registered nurse. I have been in urology for about 27 years now, and I currently work for Northwestern Medicine in Geneva and Winfield, Illinois.
All right, great. And Dr. Brownlee, go ahead.
Hi, I'm Nancy Brownlee. I also have been in urology way longer than I'd like to admit. Maybe not as long as Vic, but a long time. I am from the Houston, Texas area. I live in a suburb called Friendswood, Texas. And I was told to tell something funny. Is this the time to tell something?
This is the time to tell something funny.
So he said, say a fun fact. So I was born in Italy because my father was in the military. So that's a fun fact about me. And as a little girl, I remember my dad, very serious, saying, you know, you can never run for president if you are born out of the country. And it stuck with me because I thought, am I supposed to want to run for president? No.
Who would have thought?
I never aspired. Here I am, urology. So that's kind of a fun thing for me.
All righty. Well, let's go ahead and let you take off with your show. I'm going to bring you up.
Okay, thanks. So I am one of those proverbial lifelong learners. So I went back to school as an older adult for my doctorate. I did it at Vanderbilt University in Nashville. They have a hybrid program where you go in periodically, et cetera. And I want to give you a little history about why I chose targeted antibiotic prophylaxis before prostate biopsy. As an NP, we're told to follow urological guidelines. You know, the AUA produces guidelines. And when you're new to a specialty, and although I wasn't new to urology, I was new at the time, over 10 years ago as an NP, working. So I'd always look at guidelines. If I needed to double check things, I would. And my first place of employment, I've always been in academia. So I haven't worked in like a private freestanding setting, just always in academia, was University of Texas Medical Branch in Galveston. And the doctors there followed the guideline, and you give Cipro or fluoroquinolone, 500 milligrams a day before a biopsy. Now they do the fleets enemas and all that, but I'm just focusing on antibiotics right now. And then one the morning of the procedure, one the evening of the procedure, and then the next couple days, one a day. That was their protocol. And that was in the guidelines as far as giving fluoroquinolones, maybe not an exact sequence, but that. So I was later recruited to Baylor College of Medicine in the medical center because that is my background. I spent most of my career at Methodist Hospital, and Baylor College of Medicine is one of the schools in that setting. So I go there, and they don't really follow the guidelines exactly. They do use Cipro, but they always give 160 milligrams of gentamicin IM. Or they might give Rocephin. It depends, but they would always do that. Like, they didn't have you check anything? That was just what they did. And, I didn't really say much about that. Okay, they want to add to cover, broad spectrum, whatever bugs. So then they want me to set up a new clinic in an outer lying area called Lake Jackson, which is like an hour outside of Houston, still Baylor. And so I'm by myself, and it's all good. I'm very experienced seeing patients, and I would have my surgeon come initially once a month, and then as we needed things, every other week, and then it was like every week. So the business really grew. We needed a new surgeon full time there. So this new one comes in, and I'm just following the guidelines. I've been trained to do prostate biopsies with an ultrasound tech, not by myself, but always with the tech. But that's the way Baylor does it. So that's how I learned. And this new doctor, who's a urologic oncology fellowship trained doctor, he says, "Why aren't you doing rectal swabs?" And I'm like, "What?" Like, he comes in, tosses this article on my desk. And I said, "Well, you realize that I'm following what the bigwigs do in Houston, right? Like, I'm not by myself out here winging it." And he goes, "Well, you need to do this, this, and this," which I'm going to go through this study, because there's been shown a lot of resistance in the stool to fluoroquinolones. So if you just use Cipro, you may not have good coverage, and the patient could become septic. And it doesn't mean they're allergic, obviously, to the drug. It just means in their stool, it's shown a resistance. So rectal swab cultures can provide sensitivity if the patient is at risk for the Cipro to not work. Then I realized, that may be why Baylor just automatically does the gentamicin, just to have coverage. So then as I'm getting my doctorate back in 2022 timeframe to 24, and looking for a project, evidence-based practice, what we're taught to follow, I thought, that might be a good one, because let me just check the literature out here. There's tons of literature that says to do this, tons. Why aren't we doing it? So then I reach out to my advisor, who's on the header, Dr. McClure. And she goes, "That's really about antibiotic stewardship, to be exact, this study. It's really about antibiotic stewardship, because they're over-treating. They may not, we worry about resistance. That might be a good topic for you." With that in mind, I decided that, okay, I'm going to have to stop for a minute. My battery says it's low. So let me make sure I'm plugged in here. Sorry. I just don't want to lose y'all. Let me just get going. Let me plug that in. Okay, now, thank you. I didn't realize that was not secure. Okay, back. So I decided, she thought it would be a great project. So then it comes to finding a site. Well, Baylor said I could do it there. However, I was going to have to go through all this IRB business. And when you're getting your doctorate, they have a certain time frame to get going and to be done so you can write it up, because it's more quality improvement projects rather than like original research. Not that we couldn't do that, but so I reached out to one of my doctor friends in San Antonio, Texas, Dr. Ian Thompson. He's well known, again, fellowship trained in urologic oncology. He also has a son with the same name that's also a urologist. And his son attended Vanderbilt for their urology residency. So then I inquire with Dr. Thompson. He's now in private practice. He was chairman with the military at Brooke Army Medical Center of Urology, then University of Texas in San Antonio. What does he do? He doesn't follow the evidence base either. They don't do that. They just slam them with antibiotics, Cipro, Rocephin IV maybe, depending, gentamicin, like all this evidence in my references shows that targeted antibiotic prophylaxis, checking with the if they're resistant and choosing a different one, you don't have to give them all these extra antibiotics. So the studies are there, but we're going to do this little mini study, which he was willing to do. So we didn't have to do the IRB because he's in private practice. So that worked out quite well. So now I'm going to go into my poster presentation here and get to what the implications are and why. So as you probably know, over 1 million more biopsies are performed annually in the United States. This targeted antibiotic prophylaxis, also called TAP, is recommended, yet implementation is not widespread. So this is what I'm trying to figure out why. So the current practice is to prescribe fluoroquinolones before prostate biopsy empirically. That was the AUA guidelines. But the rectal swab has shown an increase in resistant bacteria to fluoroquinolones, causing post-procedure infections and or sepsis. So we have our typical team in the clinic, the urologist, the office manager to help get the supplies, ordering the rectal swabs, the medical assistant and or the nurse in the office to help set up the procedure, and the ultrasound technician as needed. So the aim was to see if we could reduce the number of prostate infections. Typical annual rate may be up to 5%, but make it less than 1%. And obviously our population is the male patient who has an elevated PSA and or an abnormal rectal exam that warrants a prostate biopsy. So we have everything in place. We're going to order the rectal swabs. We're going to use his patients because he has a large patient volume in the short amount of time that I needed to finish my project. And by the way, rectal swab cost is about $100. It's considered like the wound. You just use the wound swabs that you use for wounds. They send it to the lab, whether you want to use your hospital lab or Quest lab. We used Quest just as a matter of convenience. They refer to Quest at this clinic. And it was about $100. So it's not an expensive addition to the already what they're paying for the procedure. So our limitations, we had a small sample size. So we had 30 patients. So if you look, you can look at the graph that you see. 12 patients had no TAP. 18 patients did have TAP. And then if you look at the results, the 18 patients that we did TAP on, 2 of them, or 11%, which is significant, were resistant to Cipro. The other patients that the doctor normally does, he did his fluoroquinolones plus either gentamicin or Rocephin. So we don't know if they were resistant or not, but they're getting those antibiotics. At the end, there were no difference in infection rates. I think that's good to know, right? So the thing is why is this? Why is this? So this is what I learned from Dr. Thompson, who was a great collaborator on this. Fear of infection, because if they're readmitted septic to the hospital, they lose, they may not pay for it, especially if you have a large percentage of Medicare patients, which a lot of them are in the older population. And so they're doing it because clearly they don't want them to be septic. Nobody's going to argue that. We don't want any patient to become septic. But what we did implement in his office is calling the patient, unless they called us, and giving excellent patient instructions, and then following up to make sure they're not having any burning, discomfort. So that was an additional thing to follow up with. Now, yes, it is a phone call, but we were doing the study, and so that's why we wanted to make sure they were followed up with. Nobody was complaining about burning, symptoms of infection, fever, chills. So that was encouraging. So then it was like, why don't we revise the guidelines then? If doctors aren't doing this, why are we doing it? Or why are they recommending just the Cipro? So I asked around. Baylor doesn't do the rectal swabs. Vanderbilt doesn't do the rectal swabs at their urology clinic. At the University of San Antonio, the VA in San Antonio, they do the rectal swabs. So it was nice that, okay, we found some academic institution that does that. Now, granted, I wasn't surveying private practice institution locations, but that it made me think it would be nice to do a survey of who's really doing this. And then when I would randomly ask why, the answer was, well, we don't want to have to worry about the swab, waiting for results. We just rather do the coverage and be done. But is that really a good use and being a good steward of our antibiotics? Probably not. So how would you enforce that? That would be the challenge. So was there any change made to Dr. Thompson's practice? Well, he is going to be more selective on doing rectal swabs. So I think with patients with comorbidities, he's still going to do what he's doing already. But other patients, if he can reduce that, he learned himself that, hey, there's no difference in infection rate. Why are we adding this extra cost to the patient doing the antibiotics? There's been numerous large studies in the literature. The limitation on this one is it clearly was a small sample size, but there have been other studies and articles that have shown this. So I'm just putting it out there to let y'all know, if in the urology world, if you're doing it, great. And if you're not, you might want to start implementing this, since we don't really see a difference if they're following the protocol on resistance. So I'm open to questions, and if you need clarification on anything, I'm happy to answer any questions. Nobody.
This is what happens when you work remotely. I don't have all my notes.
That's okay. I know it's, I mean, I could embellish on all the points, but I'm talking to a familiar audience in urology.
I think it'd be a good one to put out for the comments. Let me know in the comments if your office is doing rectal swab or not. And why don't we start off with Lori? What's your office do?
Well, unfortunately, my office is not a good example because we send all our patients to the OR and we do fusion biopsies. So back in the day when we were doing biopsies in the office, it would just be it started out with just the standard Cipro. But then, I think the infection rate was pretty high because of resistances. We never did do the rectal swabs.
Right. I think one of the comments by different urologists, again, staying in the academic world, was that, well, you have to wait for the results, but there's no emergency prostate biopsy. See, like you do the exam, you fill a nodule, you're going to schedule the patient. It's usually not the next day. Now, I have on 2 occasions felt a man really hard as a rock, and then my collaborator, who happened to be there that day, said, well, and we didn't have our ultrasound tech, and he's only used to doing biopsies like me with the tech, their expertise. And so remember, Vic, you may remember this, the old True Cut biopsy needles. Yep. Okay. So this doctor, he said, let's have him come back, do the Fleets enema, have him come back, and I'm just going to do manually finger guided and get a couple of, you need at least 2, like one from right and left sides of the prostate, and just did a blind True Cut biopsy. But in his hands, clearly it was, perfect. And definitely was, the patient needed to get on treatment right away. He was, when I say an older man, he wasn't in his 80s, but he was over 65, and that, hey, we'd want to get treatment started because he had a very high PSA as well. So there's some things where they want to just go ahead and get that biopsy done. But most of the time, it's not an emergency. You can wait on the wound results, which take, we say allow 5 to 7 days. You might get them sooner because of the 3-day, the incubation or whatever, 48 to 72 hours. But just like we wait on urines, but we treat empirically. And then if we need to make changes, we do. Well, the wound culture of the rectal smear is just, sending it, waiting. And you probably can go ahead and post them for the biopsy ahead of time. And at least you'll know what to treat them with that would work.
So we did get some feedback from our audience, so I think it'd be helpful to bring that up here. So Susie Swain said, no rectal swabs at our clinic. Katie Portel said, my husband ended up with C. diff after prostate biopsy. and they didn't give him prophylactic antibiotics, so none at all, which is really kind of amazing. Queen Wang said we don't even have rectal swabs at our GU clinic.
Like not even for wounds?
I guess. Susie Swain said, so if rectal swab comes back negative, would you still give antibiotics prior to biopsy? That's a good question.
Okay. So you should always give the antibiotics.
Yeah.
This isn't about not giving antibiotics. It's about giving the right antibiotic.
As you said, like targeting the antibiotic.
Targeting the appropriate antibiotics. So they should give antibiotics. Whoever said they didn't give her husband, well, shame on them. They should have given antibiotics. Just like dental surgery, you're going into a dirty area, the mouth, you always have antibiotics. Rectal, even with the Fleet's enema, you always give antibiotics. It's just to target the right antibiotic to be given.
Yeah,
is the key.
Now, I can tell you in our own practice, we don't do it. And some of the arguments came up that were, I think, pretty reasonable things that, it can depend on how close to when you actually do the biopsy that the swab is done, because
correct,
delaying it can reduce accuracy as gut flora can shift. There's some concerns about turnaround times with routine rectal swabbing, cost, logistics, etc. There's been some the EUA endorses rectal swab guided targeted prophylaxis in high risk areas. So what's a high risk area? Well, if you're a healthcare worker, you're at a higher risk of being quinolone resistant. If you're traveling outside the country, you're higher risk. The AUA acknowledges the potential role, but doesn't universally recommend it due to variability in implementation. So,
well, I went online to find. So I recommended, again, with Dr. Thompson, because he knows people. I said, well, we need to change the guidelines. Well, I went to try. I had the app on my phone, AUA guidelines. Mm-hmm. It's not there anymore. I couldn't find anything. So maybe they're revising it right now. And they'll put something back up, but it has been down, like meaning it was there, but it's not there now. Yeah. About just using Cipro. And then Vic, to your point about the turnaround time is not long. It's just you have to have a lab that's used to, again, by the time you book the prostate biopsy, it's usually a week or two out. So it shouldn't be that. But I understand people would say that it's not the cost. I don't know about IV Rocephin or IM. That I don't know the cost of the antibiotics. And Dr. Thompson said personally that he that the $100 for the wound culture wasn't an issue. That wasn't an issue. No insurance rejection for covering that. And it's the same swabs most people do keep in their office for like culturing a wound or surgical things. Maybe certain offices don't keep those and they borrow them from another office, but we always kept them for other things. So they were there. So it is something about why don't they do that? Is it convenience and just easier to give them gentamicin, the extra antibiotics that increases our resistance? And as we all get older, we don't want, and with healthcare, you don't want them to take away research to find new antibiotics, right? So for me, I
know in our particular practice, we looked at the antibiograms for our area to see, and we were seeing patients getting septic on Cipro and switched over to gentamicin, and then we started seeing patients getting septic on gentamicin. So again, reviewed the antibiograms for the area and targeted Rocephin. Now I have to say the resistance or having sepsis post Rocephin treatment has been almost zero.
Correct. And one of my articles in my references is from Ohio, I believe, where they did the biogram, or what did you call it? Antibiogram?
Antibiogram,
yeah. They did that, and they found
at the hospital
the higher resistance in that region of the country on men. And so there is that, not to be confused with allergies, because when I first did this, they thought people are allergic. No, it's about just resistance in the stool, not allergic to the antibiotic. So I think we will see a different guideline probably out there. But it's not just lone me. I think people are realizing maybe we should do that. Maybe they're being selective if they do that. Maybe the patient has a lot of allergies and they want to make sure they get just the right thing. But we definitely give antibiotics. So I want to make sure that's clear.
Oh, yeah.
We definitely do prophylactic antibiotics. It's just making them more targeted. And then of course the laws, like Dr. Thompson said, if they come back to the hospital, let's say your clinic's part of a hospital. So that particular setting, they may not get reimbursed by Medicare if they come back within 30 days.
Right.
And so I just feel like that
would be the best driving force for most people.
Right. Exactly.
Lori, what do they do with the transperineal? Because you said they're doing these in the hospital. Are they, what antibiotic, do you know what they're using, or?
I don't know offhand, but they just do it in the OR. There's no, antibiotics ahead of time or anything like that. They just do it right in the OR.
Yeah.
Well, the transperineal route is getting to be more popular, which avoids the rectum and
right.
Correct. And the cost is more, obviously, but yeah, you're reducing infection. And so at Baylor, they do both, actually, depends on the patient. The fusion biopsies in the clinic, the MRI, ultrasound guided fusion biopsies. And the IV, I'm sure it's IV Rosefin, Lori. I feel quite confident.
I'm pretty confident in that, and I didn't want to say
that. But I would say that transperineal, we used to do those, and then it became more the office setting, and universally, it's going to be a while before everybody goes back to MAC anesthesia and having them admitted. I think, Vic, you're the male on the panel here. What kind would you prefer? Anesthesia, OR, or in the clinic?
I would prefer a whole lot of tests before I had a biopsy. That's a whole other subject. PSA, free PSA,
MRI,
all of those. Yeah, MRI, and then we'll talk biopsy. But no, yeah. I don't know. That's a good question. I know both the risk to transperineal versus, and that's what my mainstay was at our practice, was doing the ultrasound for transrectal.
Oh, of course,
and,
yeah. And we still do
good
that.
block. Those are really a very good, easy procedure to go through.
Exactly.
I think in the office, I think the turnaround time in the OR is a little bit quicker. Yeah. And I think that's one of the things, because we pretty much stack them up on certain days of the month, and just a ton of them in one day. And so I think that turnaround time, as opposed to doing them in the office, is quicker.
I did get a good comment that came in here I wanted to share from Deb Hensley. I work at UTSW Medical Center in Dallas, your area. We screen patients with a questionnaire, and if they have either traveled outside the U.S. in the last 6 months, a healthcare worker, or have taken quinolones in the last 6 months, we get a rectal swab. And I think that kind of goes along with what I was saying about the higher risk population.
Mm-hmm. Hey, hi, Debbie. I haven't heard from you in years.
See, you get to meet old friends, right?
He was from San Antonio. Yeah.
Yeah.
Well, I think, so in our setting, the doctor I mentioned that insisted on doing rectal swabs at the other clinic, that's how I learned about this. He said they were good for 6 months. That was his. You had mentioned, I think somebody had mentioned how long was the rectal swab.
Because they were saying
good
could
for,
change.
And he said he would keep them for 6 months in case the patient, let's say, got delayed. We had one patient that was, it wasn't an emergency biopsy again, but something he needed to get done. And he had planned a cruise, or I don't know, some transatlantic trip with the family. And we were like, oh yeah, enjoy that. Don't worry about the culture will still be good when you get back. And that kind of thing, because just in case he did want to have a procedure, there was a procedure needed or warranted. So definitely, again, it's not an emergency with the biopsies. That would be rare. There is time to get the culture back. I think on one of the patients, they had to redo the culture because the lab said they didn't have enough smear, but I think it's just more technique, guiding your finger with the Q-tip. I call it the long Q-tip, the swab, to get in there to make sure you have a decent smear on it. But with the Fleet's enemas and doing the targeted antibiotic prophylaxis, if it were my husband, he's never had a biopsy. So far, he hasn't needed one.
Yeah.
But I think I want to practice what I preach, meaning you're well informed, you have instructions, Fleet's enema, prophylactic rectal swab, prophylactic antibiotics before the procedure, monitor for symptoms, call the office, you get something on board before you ever need to go to the emergency room. Yeah. I think that would be, and then when you have a Fleet's, so at UTMB, this is another thing they also did in one of my many articles about this. Some of them would do betadine in the rectum, they would do different things. But it seems like at UTMB, they would do a Fleet's the night before and one within 2 hours before the procedure. At Baylor, they just did 2 hours before the procedure. So there are differences with that, but that was not one of the variables we looked at. But you can see all these different things you could really spend your energy on and to make it better for our future with antibiotic stewardship.
And I think you're right. There's a lot of different practices out there, and we don't really have the good evidence to say which is, worth doing. Do you do betadine in the rectum? Does that make sense? I was giving a talk to an international group on prostate biopsy, and there was a group of folks from Europe that were there, and they said, "You Americans, you're so barbaric with giving these Fleet's enemas. You can't sterilize a bowel." And
we weren't trying to.
I said, "No, you can't. That's not the idea." I said, "You just don't want stool in the way." And they go, "Yep, does not matter." They said in their minds, they said, if you go in there and you feel stool, you reschedule. And I said, "Yeah." I said, "In America, we actually don't have long vacation times like you guys go on holiday." I said, "People's time is really precious. We don't want to have stool in our way. So we always use a Fleet enema more as a convenience. It's really not preventing infection in my eye. It's just
cleaning out the bulk down there.
It gets that constipated patient, so he's not gonna have to be rescheduled."
I mean, we've canceled patients, that you don't want to feel stool. You want it. Yeah,
they're constipated. That you need to treat that.
Yeah, and that's another part of pre-patient instructions to say we're going to do this. So if you have a tendency to have that problem, maybe take care of that too.
But I think we could all agree that there's no agreement on what to do for prostate biopsy prophylaxis.
Well, I think the idea is you don't want them to get septic. You're going to do whatever you can to prevent the sepsis, and I'm very supportive of that.
Absolutely.
And the main thing is proper prep and monitoring. And most patients do quite well with transrectal. I know that transperineal now has been popularized, but there's so many private practice offices and so many things. It's not universal yet to make that the standard of practice. Let me just say that.
Lori, your office was doing transperineal before they went to the fusion, right?
No, not our office. No, we were going to do it in the office, and then they opted just to do them in the OR. A lot of it's patient comfort, the turnaround time, things like that. So they're happy with the way that they're doing it now, with doing it in the OR. So that's just how we've stuck with it. So,
well, if you said they have a better turnaround time, is that what you said?
Mm-hmm.
Turnaround. So I have an OR background. That's my background. And if they're in a procedure room or just depending on if they're using MAC, they're probably getting them totally ready in the recovery room or pre-admission, whatever, and just wheeling them in. You know what I mean? Like as you said, they've stacked them up and they're just wheeling them in. Because the equipment is in one room. Like to have that machine, you can't have the same thing in several rooms. That would be extremely expensive, So it's just one. The fusion biopsy piece is they try to just have one, and so I think they're just prepping them and just more of a procedure room than the OR room. But it's still because of the anesthesia. Does that make sense? What I'm saying?
Yeah.
They're more of a procedural room. That's part of the OR, so they can get them in and out, and they don't have to do as much of cleaning as if doing a sterile procedure. I hope that makes sense.
So, Lori, they don't do any standard trusts in the office, right?
The only time we ever use an ultrasound is to measure the size of the prostate for BPH. Otherwise, we don't do biopsies in the office at all.
Wow. Good to know.
In
case I need one, I might want to work in an OR setting.
One of the other things that would cancel a prostate biopsy if they didn't get off of their blood thinners. That's kind of a side note, but that was the one thing we always looked for more than the stool, although certainly the fleets, et cetera, is that if they were on any kind of blood thinner, made sure if they had arthritis or anything, like, please don't take anything that could thin your blood 7 to 10 days before the biopsy.
We also require a urine culture within 2 weeks of the procedure as well.
Of course.
Yeah.
And then pee at the time of the clinic. In the clinic, we would have them urinate.
So we usually do a UA. I don't know that we get a culture. If
we have to have a proven negative culture, or they will cancel the procedure.
Because of where
that's on all of our OR
procedures,
other than your circ or something, obviously. But urinary tract procedures, we do require a negative proven culture. And even if it's contaminated, we've got to have them come in for a straight cath. So that's just a requirement that we have.
I think we all have that one, but the procedure in the office, even if they have something done 2 weeks ahead of time, we'll dip their urine just to be sure it's still, at that moment before the procedure, make sure it's still clear.
Well. I mean, you want to do everything possible to prevent sepsis. I mean, any of us that have taken care of a septic patient know that's not a good thing. That's a scary situation to be in.
Mm-hmm.
Well, great. I don't see any other questions coming in. I got a little plug for next week's meeting. We're going to be meeting with the foundation, SUNA Foundation, and here's a little plug for that.
Join us for a heartwarming episode of Your Own Nurse, hosted and presented by Vic Senese as we highlight the SUNA Foundation fundraiser. Step by step, we can make a difference. In this special episode, past President Glenn Sully takes strides for charity, walking to support the SUNA Foundation's mission to advance urologic nursing, patient care, and research initiatives. We are joined by Debbie Hensley and Marianne Wassner from the Foundation to learn how you can get involved and celebrate the power of teamwork and dedication in the urologic community. Join us September 6th at 9 a.m. Central Time.
So I encourage everyone to join us next week, learn more about the SUNA Foundation. I think there's still a lot of SUNA members that don't really understand what the SUNA Foundation offers, how you can donate to keep, the urology practice going on for people who can't always afford to come to a SUNA meeting. They have scholarships for a lot of things that they support. So, and Glenn Sully, who was going to be on the show, he had a commitment that something going on with a family member that he can't make it, but they'll certainly be talking. He's got to send some slides over that. He's doing this long walk to support, and you can support him in his walk effort to get money raised for the foundation. So look forward to all that next week. So, Lori, always a pleasure having you on the show.
Thank you.
Your many years of expertise. And Nancy, welcome to the show for the first time.
Thank you. I'm
You're
glad
an official podcaster now.
Well, I'm excited. I've listened to numerous things, Vic, and I've seen Lori several times. So I feel like probably like several audience members, we feel like we know you, even though you don't know us.
Exactly. You're now part of the UroNurse family. We look forward to hopefully getting some follow-up in the future on this. Really enjoyed having you on the show. So we'll see everybody next week. Have a great and safe Labor Day coming up. Can't believe summer's over, huh? But it is. So enjoy your time that you have left for summer and do something.
So here's to the morning, the coffee, the monitor glow, to the wisdom he shares and the folks that he knows. Saturday is special when Vic's on the stream with 40 years of knowledge and a head full of dreams.